So let's cover the important points covered under the topic of portal hypertension, which are asked frequently in the exam. So coming first to the definition of portal hypertension. Portal hypertension is prolonged elevation of portal venous pressure more than 30 centimeters of normal saline. The normal portal venous pressure is around 10 to 15 centimeters of saline. The definition also says that it is portal hypertension is elevation of hepatic venous pressure gradient. What is hepatic venous pressure gradient? It's the difference of pressure between the portal vein and the hepatic vein. And the elevation of hepatic venous pressure gradient should be more than 7 mmHg to call it as portal hypertension. The hepatic portal venous gradient more than 10 mmHg defines significant portal hypertension. Coming back to basics, sites of portosystemic anastomosis. There are 6 sites. One is along the lower end of esophagus, which is the portal branches, esophageal branches of left gastric vein, and systemic branches the azygous vein. Upper part of anal canal is the anastomosis between superior rectal vein and middle and inferior rectal vein. The superior rectal vein is part of portal circulation, whereas the lower part, that is the middle and the inferior rectal vein, is a part of systemic circulation. Caput medusae, that is around the umbilicus. The portal veins is the veins of the ligamentum teres, and the systemic veins are superior inferior epigastric veins. The fourth is the bare area of liver. The portal is hepatic or portal vein. Systemic is inferior phrenic vein. Patent ductus venosus, which is rare. It is the left branch of portal vein and inferior vena cava. And retroperitoneal between colonic veins and the body wall veins. So these are the 6 important sites of portocaval anastomosis. So coming to the classification of portal hypertension, it is pre-sinusoidal, sinusoidal and post-sinusoidal. So pre-sinusoidal is extrahepatic and intrahepatic. Extrahepatic will be all the causes before the liver, that is portal vein thrombosis and splenic vein thrombosis. Intrahepatic, it is schistosomiasis, primary biliary cirrhosis, chronic active hepatitis, congenital hepatic fibrosis and sarcoidosis. Coming to the sinusoidal causes are basically the causes of liver, that is cirrhosis, vitamin A intoxication and cytotoxic or hepatotoxic drugs. Now post-sinusoidal is beyond liver, that is which is intrahepatic as well as extrahepatic. So intrahepatic will be any veno-occlusive disease like Budd-Chiari syndrome. Extrahepatic is hepatic vein thrombosis. So this is a very important chart regarding classification of portal hypertension. I'm sorry for the quality of this chart, like the quality of the photograph, but I didn't find this chart anywhere, so I had to put this. See, this is the part which I covered in the previous slide, right? Now the non-portal causes of portal hypertension. So let's start with from here. Traumatic, that is blunt abdominal trauma or penetrating trauma. Post-operative, that is abdominal aneurysmal repair. Post-liver transplant, retroperitoneal node dissection and inferior cava resection, IVC resection. Neoplastic, like solid organ malignancies like carcinoma, lymphoma, mainly high-grade non-Hodgkin's B-cell lymphoma especially, lymphangiomyomatosis, carcinoid tumors and Kaposi sarcoma. So these are the neoplastic causes of portal hypertension. Infectious, one is very common in our country, that is tuberculosis, filariasis and Mycobacterium avium intracellular complex. Inflammatory causes are radiation, pancreatitis, retroperitoneal fibrosis, sarcoidosis, celiac sprue and Whipple disease. Now congenital causes, especially seen in the pediatric population, is primary lymphatic hypoplasia, yellow nail syndrome, Klippel-Trenaunay syndrome, primary lymphatic hyperplasia, or intestinal lymphangiectasia. So these are the causes. This chart is very important, which is not given in many of the books. That is the non-portal causes of portal hypertension. So coming to the complications of portal hypertension, from head to toe, you can say it is hepatic encephalopathy, gastroesophageal varices or gastroesophageal variceal hemorrhage, liver cell failure, hepatocellular carcinoma, ascites and spontaneous bacterial peritonitis, and hepatorenal syndrome. Hepatic encephalopathy is a separate entity. I'll cover up in a different slide. Gastroesophageal varices. So variceal bleeding and perrectal bleeding is very important symptom you asked in the case of portal hypertension. Signs of liver cell failure will be present. Ascites and spontaneous bacterial peritonitis. Ascites is a sign of decompensated liver cell failure. And hepatorenal syndrome. In case of hepatorenal syndrome, there is a rise in urea and creatinine in patients who are not on any diuretics and without any obvious renal cause with signs of hepatocellular failure. And reversal of the hepatic pathology will cause increase in, will cure or will bring down the urea creatinine. So this is a very important slide of which talks about hepatocyte signs of liver cell failure and effects of portal hypertension. So signs of liver cell failure are from head to toe coma, theater hepaticus, that is breath which smells like a freshly opened corpse, spider nevi, gynecomastia, jaundice. So, spider nevi are present on the distribution of SVC, that is superior vena cava, ascites, loss of sexual hair, testicular atrophy, liver flaps or flapping tremors, or you call it as atrexis, coarse hand tremor, bleeding tendency due to decreased prothrombin time, due to decreased prothrombin, that is manifested by increased prothrombin time, anemia, that is microcytic or iron deficiency anemia, due to blood loss from the esophageal and the lower GI bleed, and pedal edema. Now coming to the effects of portal hypertension, the most important is esophageal varices, which will ultimately cause hematemesis. There will be gastropathy, there will be melena. An important like absence of splenomegaly almost rules out portal hypertension. So splenomegaly, dilated abdominal veins, or also known as caput medusae, around the umbilicus, ascites and rectal varices or the hemorrhoids. So complications of portal hypertension are variceal bleeding, hepatic encephalopathy, ascites, spontaneous bacterial peritonitis, hepatorenal and hepatopulmonary syndrome, congestive gastropathy, hypersplenism, and iron deficiency anemia. Coming to the treatment of portal hypertension, the primary treatment is identifying the underlying cause of portal hypertension and treating it. Non-selective beta blockers like propranolol, somatostatin and its analogs like octreotide, vasopressin, alpha-1 blocking agents like prazosin, angiotensin receptor blockers, and nitrates.